So in this video, we're going to cover Pneumocystis jirovecii. This is kind of an interesting organism. For years and years, it was known as a parasite, and we taught it as a parasite, and we referred to its various forms using parasitic terms. And then we got better at genetic sequencing and found out that it actually behaves a lot more or actually has the ribosomal RNA structure and cell wall that are more similar to a fungi or a fungi. Bad micro joke, but you get it. So basically, we took a parasite and we made it a fungus by basically digging into it more. But it almost behaves more similarly to a parasite, besides the fact that it actually has fungal similarities. So this is kind of an odd organism. It can exist as free trophic forms, as a uninucleate sporocyst or as a cyst. And then, so if you look over here, this is like a whole cyst, right? And then it has all of these little sporocysts inside, and then it'll rupture, and these trophoblasts, rather, will come out, right? So this is kind of an empty capsule cyst that used to hold all of the good stuff in here that would actually set up a infection later on. It's a major cause of pneumonia, particularly in immunosuppressed patients, and really is kind of a scourge for the HIV positive community because it's largely an opportunistic pathogen. Um, we don't know where it comes from. It's unknown. Airborne transmission of it has been documented, and it's known that the respiratory tract is how it gets in. And it has this, like I said, this parasitic-like life cycle where you've got trophozoites inside the cyst, and they form in the alveolar spaces of the lung, and then the trophozoites multiply to form mature cysts that then rupture, releasing these trophozoites out to create new infection. But where it initially comes from to get into our lungs is somewhat unknown. The clinical syndrome is very simple. It's pneumonia. Like I said, it's a significant concern for anyone with an impaired T cell function, and it's really the most common opportunistic pathogen in the HIV community, but it can also be a significant concern for other immunocompromised individuals as well. When we think about the pneumonia, um, what we see is most likely a reactivation. So this patient probably was exposed to pneumocystis at some point, got it kind of under control, locked in, kind of like what we associate with TB. And then as their CD4 counts go down and their immune response, their cell-mediated immunity goes down, then we see this reactivation of this latent lung infection. And there can be this subacute onset fever, dry cough, dyspnea, and hypoxia. And that can actually progress to acute respiratory distress syndrome, which again is that fulminant inflammatory response. And so at that point, it's not really the fungal infection that's a problem. It's actually the inflammation that winds up causing a problem for the patient. And this one's it's a really unfortunate disease because mortality with this one, even with treatment, is pretty high, anywhere from 20 to 60%. So it's a pretty devastating one. Diagnosis is largely made by morphologic identification of the organism in the tissue. The tissue can be stained with GMS for cysts or GEMSA for trophozoites. And then you'll see this, you can do a microscopic examination of the bronchoalveolar lavage. That's one of your specimen sources. We can't really culture it. It's one of the few times that I'll tell you that culture is not the gold standard. It's not routinely done because it's incredibly difficult to culture. So really we're just looking for the trophozoites or the cysts in the tissue. Treatment can be done with trimethylsulfa or IV pentamidine. Trimethylsulfa is actually kind of more common, and you can actually use that to treat prophylactically. So if you have an HIV positive patient or an organ transplant patient who's significantly immunosuppressed, who's kind of at high risk for reactivation of a previous pneumocystis infection, you're going to want to put them on trimeth just to kind of protect them should the infection reactivate.